My name is Dr. Mark Socinski, and I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I'm also a thoracic medical oncologist and a member of our thoracic oncology program at the Advent Health Cancer Institute. Let's discuss the role of palliative care in the management of advanced non-small cell lung cancer. I want to start by reminding everybody of the trial that was done by Jennifer Temmel at the Massachusetts General Hospital. The Massachusetts General Hospital has an outstanding lung cancer program, very good thoracic medical oncologist. What they did in that particular trial is to randomize patients to standard care by these expert lung cancer physicians versus a palliative care intervention and palliative care option for patients. Those were the two arms. The variable was palliative care input. This trial was published in the New England Journal of Medicine, had a very powerful impact, at least in the lung cancer arena, because what it showed was that it improved quality endpoints such as a greater use of hospice, less use of chemotherapy in the last 2 weeks of life, a greater rate of defining advanced directives, lower depression scales, better management of depression, better pain management, these sorts of things. And strikingly, what was the icing on the cake, if you will, was that there was actually an overall survival advantage for these patients that were managed coincidingly with both medical oncologists. And again, these are not your average run-of-the-mill medical oncologists. These were thoracic medical oncologists at the Massachusetts General Hospital who focused on lung cancer. So they were highly subspecialized physicians, but even with their expert care, the addition of a palliative care physician led to these very important endpoints. And this was very influential, not only to me personally, but to the greater lung cancer community as a whole. At the time, I was at the University of Pittsburgh. We incorporated the palliative care physician assistant into our weekly clinics. It was very helpful. Currently, when I see patients in my current position, I see them side by side with a palliative care physician who's integrated in our clinic and really is introduced at the time of diagnosis. There may not be major palliative care needs at that time, but the relationship is established. It's very helpful to me personally in that the palliative care physicians, I think, are very adept at things that we in medical oncology may be less expert at. Let's just leave it at that. And so it really is a really nice collegial, collaborative, helpful relationship from my point of view, because I can, kind of stand arm in arm or hand in hand with our palliative care physician and feel like I'm really addressing a comprehensive approach for the patient that not only incorporates my expertise, which is really understanding their lung cancer, understanding their stage, their diagnosis, getting them to the right therapy at the right time, those sorts of issues. And also our palliative care physicians focus on the issues around the diagnosis of cancer, managing depression, very helpful in managing pain issues, really get a good sense of what the patient's goals are, their advanced directives and these sorts of things, all of which are important to define really early on. So I think it's a vital opportunity, and we either have to be better at it as medical oncologists, or we have to engage our palliative care people to help us manage the lung cancer patient. Because based on, again, on the Temmel's trial, can have a major influence on the management of lung cancer patients.